Well, my name is Pablo Martinez Lage. I'm from Fundación Cita Alzheimer in San Sebastián, in the north of Spain. Well, Alzheimer's disease is a neurodegenerative disorder characterized by cognitive symptoms, behavioral and psychological symptoms, and during the process of the disease, a loss of functional autonomy. And that's what we call dementia. The way Alois Alzheimer described it, Alzheimer's disease is a neurodegenerative disorder characterized by the deposition of amyloid in the form of senile or neuritic plaques in certain parts of the brain, together with what we call neurofibrillary tangles, which is a pathological finding inside neurons. And then senile plaques contain amyloid, and neurofibrillary tangles contain tau as proteins. For years, Alzheimer's disease has been diagnosed on the basis of exclusion. If a patient had dementia and you were able to exclude vascular causes, tumors, hydrocephalus, vitamin deficits, or hypothyroidism, or other disorders, if you were able to exclude the 60 or 70 causes of dementia, then you were left with Alzheimer's disease, and you diagnose your patients by exclusion. In the last 5, 6, 10, 8 years, we have available methods to know whether a patient has amyloid and tau in their brains, and that's thank you to PET imaging and CSF biomarkers analysis. So today, Alzheimer's disease is a neurodegenerative disorder characterized by cognitive symptoms, not necessarily dementia, and positivity of Alzheimer's biomarkers in your CSF on your PET imaging. The title of my talk is State of the Art in Pharmacological Interventions in Alzheimer's disease. So what I'll try to do is to explain all the things we know about the pathogenesis of Alzheimer's disease and how amyloid is involved in these pathogenesis and all the amyloid cascade hypotheses and so on. And from there I'll try to set what the therapeutic targets have been so far, and then try to tell the audience about the failures with all the anti-amyloid approaches that have been tested so far. And then I'll get into the, I'll also mention about other potential therapies, like those related with tau pathology or the anti-tau pathology therapies. And then I'll talk a little bit about the 4 approved drugs, donepezil, rivastigmine, galantamine, and memantine. I'll try to introduce the hot topic of combination therapy and when to stop these drugs. And then I'll try to introduce the problem or the questions related with prevention of Alzheimer's disease, talk a little bit about mild cognitive impairment and how to prevent that this goes into dementia, and then talk a little bit about preclinical Alzheimer's disease therapies that are already being tested in this stage, and then I'll talk in my last slide about risk factors.
I'm Régis Bordet. I'm a professor in Lille, in the north of France. And as Pablo said, we have a big challenge for the Alzheimer's disease treatment because of the failure of many drugs that have been assessed in patients for a long time. And this challenge explains why it's not time now to compete between disease modifier and symptomatic treatment. It's not time to compete between pharmaceutical companies and between all academic team, but it's time to collaborate between us to improve the development of drugs in Alzheimer's disease. And it's why we're in Europe, European Union, and in a specific program that is called Innovative Medicine Initiative, support a program for 5 years that is called PharmaCog, to improve the assessment of drug in Alzheimer's disease, in particular in the early phase of development, to favor the go-no-go strategy and to say early if this drug could be interesting in Alzheimer's disease or not. And this program is organized with a huge network in all Europe. We are three representatives of this program, an Italian people, Spanish, French. So we have built a very huge consortium, including 12 pharmaceutical companies and 5 SMEs, with interaction with the European Agency of Drug. And in this program, in both preclinical and clinical, we have developed a battery of biomarkers to better assess the impact of a drug that could be relevant for Alzheimer's disease. And we have many programs, many clinical trials, many programs in animals to test this biomarker. And David will explain in his talk the importance of this clinical trial and the importance of neuroimaging, and Claudio will emphasize the interest of EEG as a biomarker for the drug development in Alzheimer's disease.
So my name is Bartrés-Faz from the University of Barcelona, and as Régis, Professor Bordet said, I am involved within the pharmaceutical project. I am particularly coordinating what we call the cognitive challenge models in humans. So I will be explaining in my talk how we are trying to induce transient cognitive impairments to test reversibility by first by marketed agents, donepezil and memantine, and therefore here in phase 1 studies with young volunteers to have some hints of efficacy of reversibility of cognitive impairments, in building a model that is also parallel, and we will have feedback, translational and harmonization feedback from patients and from animals on the other side, so to help the industry when this model is built and tested with new developing compounds, to help the industry to decide earlier go-no-go decisions, and then the interest of these terminating early clinical trials that are not going to be successful and investing on the ones that give positive responses. And for this I will explain how we have developed 2 cognitive challenge models, which are sleep deprivation and transcranial magnetic stimulation, which we have now finished the clinical studies and are analyzing now the data within this pharmaceutical project.
My name is Claudio Babiloni. I'm professor of physiology at the University of Rome La Sapienza. My role in the pharmaceutical project is to coordinate the use of EEG biomarker, electroencephalographic biomarkers of Alzheimer's disease. And for the diagnosis and monitoring of Alzheimer's disease, today people use measurement of a beta amyloid in the brain, or tauopathy, or atrophy of the brain with magnetic resonance imaging and positron tomography, emission tomography. And EEG is not used in the clinical practice. Anyway, recent studies have shown that EEG biomarkers are an interesting candidate for the drug development in Alzheimer's disease, because they can provide back translation EEG markers, because you can record EEG very easily in animal models of Alzheimer's disease. And in pharmaceutical, we tested the EEG biomarkers in humans, in people with amnesic MCI and healthy volunteers. And we will define paradigms to record EEG in similar conditions in mouse models of Alzheimer's disease and lemurs and octogons. And in my talk I would present the new results in amnesic MCI people and animal models of Alzheimer's disease. And the results are really promising, and we hope that pharmaca could contribute with new EEG biomarkers to the field.
Do you think that the failure of new drugs could be explained by this stage of go-no-go in early phase of development of drugs, and if some biomarker could improve this development?
I think that's a very interesting question. It seems that during the last 10-15 years we have learned a lot on the mechanisms of Alzheimer's disease. We have learned a lot on amyloid and on tau and everything about inflammation and the vascular contributions to dementia. And despite that, all the therapeutic approaches that have been developed based on this knowledge on the pathogenesis have failed. And then a lot of questions come up. Have anti-amyloid drugs failed because amyloid is not important? Have they failed just because they have been tested too late in the process of the disease? Or have they failed because amyloid is not sufficient? Maybe you have to try to focus on amyloid plus tau plus inflammation or whatever. So I think that these kind of initiatives of multi-biomarker approaching and this paradigm of cognitive pressuring or challenging people, I think the answers to these questions should come from those projects first before any drug gets into the phase 1, phase 2, phase 3 trial, because a lot of money has already been lost. It is of concern that companies are starting to lose their interest in Alzheimer's disease, and Alzheimer's disease is a big challenge of our society.
We are in the valley of death in the drug development in Alzheimer's disease.
I wonder if we can talk about one single disease with Alzheimer's disease, or a family, or various and different profiles of neurodegenerative mechanisms, and so appropriate therapeutics. What's your view?
Extremely good question. Very good question. Because we tend to think that Alzheimer's disease is the same in everyone, and it's not. It's not. Pathology is telling us that many people die with Alzheimer's pathology in their brains, even with Alzheimer's plus vascular pathology in the brains, but they don't have any cognitive symptoms. Pathology is telling us that some subjects only have amyloid, some subjects only have tau. Mixed pathologies are the most frequent finding. So it seems that what we consider Alzheimer's disease is amyloid deposition plus tau pathology might be the end of a process to which you can get from very different etiologies. Alzheimer's pathology has been related to hypoxia and ischemia, so that might be one starting point. It has been related to traumatic brain injury. It has been related to genetics, genetic predisposition. So, and if you put into the model that thing about cognitive reserve, then it's very, very complicated. So Alzheimer's disease is very heterogeneous. We are only looking at the end of the process. We need to understand much better what happens before amyloid starts to deposit, because if the mechanisms are different, then the treatments are different. This happened with the paradigm of MCI, of mild cognitive impairment. Peterson established his model. It was very clear-cut, very nice criteria. And then everyone started to talk about MCI, the amnestic, non-amnestic, single domain, multi-domain, whatever. But the bite point was that researchers and pharmaceutical companies got into treating MCI with these cholinergic drugs. They failed. The fact is that they put into the trials people who had Alzheimer's, MCI, but also depression, vascular MCI, any kind of MCI. So cholinergic drugs failed. I wonder what might happen if these trials were repeated in people who have MCI plus positive biomarkers. People who have MCI due to Alzheimer's, maybe these drugs might work. And if these drugs work in people with MCI, you would be preventing, at least for 2 or 3 years, the development of dementia. So your question is very good. We should try to make much more homogeneous groups.
So what do you think as regards the approval of the compounds that are being tested by the regulatory entities and the criteria for approval? Do you think it should still remain only symptomatic in terms of cognitive enhancement? What is the value, the importance of the change in a biomarker, or as regards the approval and marketing for a given compound? This will need to be both cognitive enhancement and changing some biologic parameter? What is your view about that?
And still, it's probably not the most important symptom for patients and relatives. I mean, relatives are much more overloaded with behavior or with loss of functionality. So maybe those might be the most important points. We are facing different stages of Alzheimer's disease. So if you go to the mild, moderate, or advanced patients, of course you need a clinical endpoint. I mean, of course you need to have some significance into something that may be perceived by patients and caregivers. If you focus on MCI, the best endpoint would be delaying dementia. So it's not necessary that you get improved cognition, but that you delay the loss of autonomy of patients. That might be a good endpoint. And then if you focus preclinical Alzheimer's disease, that is asymptomatic people with positive biomarkers, I think this is a very slippery field. Why? I'll show a slide later of a study we made with the mathematical models of disease, showing that by the age of 80, almost 70% of the population have amyloid in their brains, but only 30–40% have dementia. So if you start treating people with no symptoms and amyloid in their brains, you will be treating 40% of people that would never develop dementia. So you're going to spend a lot of money, you're going to put these subjects into the risk of adverse events, and these are subjects that were never going to get dementia. I wonder if it is too early to start treating preclinical subjects. We should know, and I think this is part of the research that should be done now. You have preclinical subjects with positive amyloid, but we need biomarkers telling us that amyloid is producing damage. Maybe EEG, I don't know, or inflammation markers or whatever, and then focus on those populations who are at a very high risk of developing symptoms. We still have to learn a lot about the natural history of not only preclinical but also prodromal Alzheimer's disease. So it's very difficult, and we should have learned the lessons from MCI.
I agree. I think there is very ethical concern in for this prodromal stage of Alzheimer's disease, only on genetic or only on imaging with amyloid deposition. The stratification is probably one of the big challenge in the future. And I have a question for both David and Claudio. Do you think that beyond the use of biomarker, battery, or pharmacology in terms of drug assessment, do you think that biomarker could contribute to the stratification of patients?
Yes, it's one of the work packages of pharmacology, a focus on amnesic MCI people, and we divided these people into groups on the basis of positive markers of beta amyloid and tau in cerebrospinal fluid. So we classify as possible prodromal Alzheimer's disease people with positive biomarkers in terms of beta amyloid and tau. And we could demonstrate that we have really specific patterns of brain atrophy and also abnormal EEG activity in MCI people positive to CSF when compared to amnesic MCI with the same cognitive impairment but not positive to CSF. And we could also demonstrate that other neuroimaging and EEG biomarkers were able to capture the progression of the disease at 6 months and 12 months follow-up. And now we are processing data on 18 months and 24 months follow-up. Wonder if Régis thinks that pharmaceutical project can also contribute to a biomarkers field of Alzheimer's disease with blood biomarkers, or if we are far from this.
Now we have no data beyond what we know on classical biomarker, amyloid, tau, and inflammation. I hope that we can identify some new biomarker with our program related to abnormalities in brain functioning and so on.
What we have observed in the studies that we conduct in young volunteers by inducing cognitive challenges is that there is differences, individual differences. Some individuals are affected cognitively by the challenges, sleep deprivation or transcranial magnetic stimulation, and others not. And using functional neuroimaging images, EEG or fMRI for instance, we can see already that some subjects do express some kind of compensatory reorganizations, and there is no impact on performance. So this links to what Pablo said before as regards cognitive brain reserve. So maybe if we can translate this information to the patients or identify if the compensatory patterns are similar of what we see in patients, we can have some biomarkers already saying that these are more or less likely to respond to pharmacological manipulation.
Thank you all very much.
You're very welcome.
Thank you.